We're going to be talking about hip and knee problems, and what we're going to talk about, what I'd like to do is I want to review the spectrum of treatment options for developmental, traumatic, degenerative, and inflammatory hip conditions. When you start medical school, the first class you take is anatomy, so it's important to understand the anatomy to really understand any condition. So we'll start with the hip, and this is the femoral head. So the femoral head is the ball, and the acetabulum is a socket, and this is a ball and socket joint, and around the acetabulum, this is the ligament of Teres. That's where the blood supply comes through when you're a baby. But when you're an adult, there's really no blood supply coming in here. All the blood supply comes up the neck. So if you have a fracture of the neck, that's why a lot of people will replace the hip, because the blood supply is disrupted by that fracture. Fibrocartilage structure that surrounds the socket. It's like a scar cartilage. It's almost like a rubbery type of tissue. And if it's torn, it can cause pain and mechanical symptoms. The synovium is the lining of the joint. That makes joint fluid to help lubricate the joint. And normally it makes just a small amount of joint fluid, so it's just perfectly lubricated. But if it's inflamed, it makes more fluid than your body can remove. So it's like if you turn the faucet on and the sink can't keep up, the fluid builds up, and that's why somebody would get a swollen knee or may get discomfort in the hip. You usually can't appreciate swelling in the hip because it's such a deep structure, but that can be from inflammation. We'll start talking about trochanteric bursitis. Trochanteric bursitis is inflammation not in the hip joint, but of the bursa that's over the side of the hip. People will call it hip bursitis, and it's pain on the outer part of the hip. There's inflammation and thickening of the bursa. It can be associated with a fall onto that side or an injury, or it may just be from tightness of those muscles. And anytime you have any other hip problem, like a labral tear or something, that alters the way you walk and the way you move and the way you stretch, that can lead to tightness of those muscles and can precipitate bursitis in addition to the symptoms related to the other hip pathology. And it's associated with a tight iliotibial band. And normally the treatment is rest, anti-inflammatory medications. Heat is very helpful in relaxing the muscle. Sometimes physical therapists will use ultrasound. Stretching of the IT band is critical for this, and physical therapy is really the mainstay of treatment for this condition. Occasionally, if somebody is too uncomfortable to stretch in therapy, a cortisone injection can help diminish the pain temporarily, but it doesn't solve the problem. So therapy is still a very, very important part of solving the problem, even if you undergo an injection. A muscle strain is going to be something that's more common in young patients and athletes. It's usually related to a sudden stretching injury. They call it happens from what we call eccentric contraction. That's when the muscle is contracting as it's lengthening. And the muscles that are most at risk are the muscles that cross two joints, because they can be stretched at both sides at the same time. So the hamstring muscle is commonly involved. Sometimes the quadriceps muscle, calf muscles, those are all muscles that cross more than one joint. And it results in pain in the injured muscle, and it can be associated with pain with walking. Initially, again, your rest, ice, compression. You can use crutches to minimize weight bearing. As you're able to walk without any pain, you get rid of the crutches. And once you have pain-free range of motion on stretching, then it's okay to start gentle strengthening. You don't want to start strengthening before the muscle has a chance to have healed. Now, when we start talking about true intra-articular hip pain, most people will feel that in the groin area, in the front of the hip. Some people will say it's C-shaped, like a C around the hip. And often it will go down the front inner thigh towards the knee. And it may even go down just below the knee to the tibial tubercle, but hip pain should not go down in the lower leg. So pain that goes into the lower leg is more likely going to be a pinched nerve from the back or some other pathology. But true hip pain shouldn't go below the tibial tubercle. It can be associated with pain with rotation of the hip, particularly if you bend the hip up and you internally rotate it, or turn the foot out and the knee in. It can be associated with pain when you have resisted flexion. You'll see people with hip arthritis, a lot of times they will help their leg with their arms because it hurts to actively flex their hip. There's a test called McCarthy's test that's done for labral tears, and essentially if you bring the leg back down in slight abduction, you can hear a clunk or feel a clunk, and that's to look for a labral tear, not specific arthritis. And then you also want to make sure that there's not bursitis or there's not referred pain from the spine, from an ovarian cyst, from a hernia, or from some other source. So you want to make sure that if you're seeing somebody, that their pain is truly from the hip joint. The diagnostic studies we get include x-rays, and I like to get x-rays of the pelvis and then x-rays of the hip both from the front as well as from the side, and those are called lateral views. An MRI can be helpful in some cases when you suspect something called avascular necrosis, if you suspect any type of tumor or anything like that, or if you suspect a labral tear or some type of loose bodies. MRI arthrogram is more helpful if you suspect a labral tear or loose bodies or some internal problem. That's going to be more accurate than a regular MRI. That's an MRI where they inject gadolinium or dye into the hip joint, and it helps to isolate those things better. If you have somebody who has a pacemaker who can't get an MRI, you could do a CT arthrogram instead of an MRI arthrogram, but that's rarely done. That's more invasive, involves a lot more radiation. And a diagnostic injection is when you inject numbing medicine into the hip joint. So if you're not sure if the pain is coming from the hip or the back, if you put numbing medicine in the hip joint and the pain goes away temporarily, you know that's pain from the hip joint. It wouldn't have helped the pain from the back. It wouldn't have helped the pain from a cyst in the ovary. It wouldn't have helped the pain from a hernia or something else if it was injected into the hip joint. So that's a very, very helpful test. The surgical options for hip conditions include hip arthroscopy. That's like a knee arthroscopy where essentially you put a fiber optic camera into the hip and you can see what you're doing, and you can remove labral tears, you can trim them, you can remove loose bodies, so you can do a lot of different things, but you can't solve arthritis. You can't put cartilage back when you're talking about arthroscopy. Surgical dislocation is something that's been popularized initially in Switzerland, and with reshaping, that's for impingement, and we'll go into that in a little more detail, and it'll be better illustrated with the slides. Pelvic or femoral osteotomy is where you cut the bone and make it more normal if it's abnormal, and we'll talk about that, and it'll be better illustrated later. Hip resurfacing is a hip replacement where you don't cut the neck, you just recap the femoral head, and I'll give you an example of that. A total hip replacement is the hip replacement you hear about, and we'll go into some more detail on that, and then sometimes people who've had hip replacements that fail may require a hip revision, which in some cases may be more complex. So the indications for hip arthroscopy include labral tears, loose bodies, a focal injury to the cartilage, impingement problems, a tear of the ligament anterior, that's that ligament that the blood supply came in that we looked at earlier. Some people may consider it for arthritis, but it won't solve arthritis, so it's very rare that you would use it in the setting of arthritis. Septic arthritis, you can use it to wash out infection. If you have a snapping hip, you can release the iliopsoas tendon through that procedure. And then some people are using it now for peritrochanteric disorders that don't respond to therapy, but there's not really good data to say how effective it is in those areas. And that's not something that I personally would favor just because there's not good data at this time. This is an example of hip arthroscopy. So this is the ball, this is the socket, this is the labrum, this is a tear in the labrum. You can see how the cartilage has been rubbed away from this tear moving back and forth here. And we can put in little instruments so we can see what we're doing, and we can have these little shaver braids and all these little instruments. And we have all kinds of different instruments to allow us to sew and remove tissue, and we can deal with that problem, but we can't solve arthritis with this type of procedure. This is us repairing a labral tear. So these are an anchor that has sutures coming out of it. The sutures are tied around the tear to sew it back, so that can be done. And now we'll talk about impingement. When it's on the ball side or the femur side, that's called cam. If it's on the socket side, it's called pincer. And if it's on both sides, it's called combined. And we'll go through this in a little more detail. This is probably more of a physician education talk, but this is just the different definitions of impingement. And impingement is common, especially on the femur side in young active males. And this is what we're talking about. Normally there should be a concavity of the neck. And here you can see this bump. So you can imagine as this person, and this is the front of the body, this is the back of the body. This is the head, this is the feet. So you can imagine as this person bends their hip forward, as if they're sitting or they're bringing their thigh to their chest, this bump at some point is going to hit the front of the rim. The labrum is the cartilage that extends from the front of the rim, and you can see there's a tear in the labrum here from that repeated abutment of that lesion. If that area was removed, you would be able to bend it up further before it impinged. So that's one of the reasons that people get labral tears, and that can also cause cartilage damage and arthritis. And there's certain things you can do for it. Pincer means the socket, instead of facing forward the way it normally should, it faces forward either less than normal or it faces backwards. So you can imagine if my socket should face forward because I bring my thigh to my chest, I don't bring the back of my thigh to my back. So most people's sockets naturally face forward because you bring your hip forward a lot more. If it didn't face forward as much, it would hit earlier. The neck would hit the front of the femur. So you can also impinge, even if you don't have any problem on the femur side, if the socket isn't rotated in a normal position, you can impinge earlier. So when you have this crossover sign, this is the front of the socket crossing over the back of the socket, which it shouldn't. Normally, the back of the socket should always be behind the front of the socket. There should be an ellipse here. But this person has this, and then those people also have prominence of the ischial spine because the pelvis is rotated posteriorly abnormally. So those are just different physician signs. It's probably beyond the scope of this talk, but trying to give you guys a better understanding of that. So the natural history of this is not well understood. This was originally described in the German literature by the Swiss group back in 1999. So this isn't something that physicians have been following for decades and really have a good understanding of what happens if nothing's done in these situations. We know the patients continue to have pain because they come and see us and they're in pain until something happens, but we don't know how quickly they get arthritis. And we know some of them get arthritis, but we don't know how quickly and whether or not if we do intervention, how well we are at preventing them from getting arthritis. When symptomatic, these patients often will have tears of the labrum as well as delamination of the cartilage. And the pincer patients, they get labral tears earlier, so I think their prognosis is better because they have less cartilage damage. The treatment's controversial. You can treat it non-operatively. Surgically, you can treat this with arthroscopy. You can do a limited open approach. Combined with arthroscopy, you can completely dislocate the hip and reshape it, or you can, if there's a problem with the socket, you can cut the bone around the socket and rotate the socket to a more normal position. And there's a lot of controversy as far as what's the best way to do it. So this is an example of an arthroscopic view of somebody who has impingement, and this is where the blood supply comes in. That's where the blood supply comes in. That's called the medial synovial fold. And then this is the bump here that's covered with a little bit of scar cartilage. And what you can do with this is you can put a burr in, and here's a burr, and you can remove that extra bone with the burr. And I'm not going to show you all this because it would take too long, but basically that's what it looks like when you're done. So this is the cartilage. This is what's been removed with the burr, and then you can reshape it arthroscopically. If you have it on the socket side, you can see this torn labrum, and this is how they often look when you have what happens is that bone, the labrum gets pinched between the bone, and the bone has a sharp edge, and it really shreds that labrum. So it's usually in pretty bad shape when you see it. And you can trim that away, and you'll see bone behind this as you trim it, and that's from that pincer lesion. And you can see here the cartilage is pretty good. So these patients, their prognosis is pretty good because the tear happens early before there's damage to the cartilage. When there is damage to the cartilage, in either of those cases or in other cases, you can put holes in the bone, and that can help scar cartilage form because there are what they call mesenchymal stem cells, or stem cells your body has that have the ability to form scar tissue or scar cartilage in an area of a defect. This is a condition called synovial chondromatosis. Your body gets, your synovium, which normally makes joint fluid, gets confused and makes a bunch of cartilage balls that become bone. And you can see this person has like 30 or 40 of these things. They're all over the place. And and they impinge and get stuck between the surfaces, and they can cause damage to the actual joint. But these people have tremendous pain relief after these are removed, even if they have joint damage, because it's just so much more painful to have all these little loose things floating around your joint. And these are all the ones we took out of that patient. So you can imagine how painful that was. But so that's another thing you can do arthroscopically. So arthroscopy allows diagnosis and treatment of several increasingly common hip disorders. It's rarely indicated in the setting of injections. The best candidates have pain from the hip joint. They have mechanical symptoms, catching, popping, locking. They have unstable labral tears or loose bodies and have no arthritis because you can't fix the arthritis. So those are the people who do the best with hip arthroscopy. Hip resurfacing, that's a procedure where essentially you're doing a hip replacement, but rather than cutting the neck here like we normally do and having a stem that goes down here, you just have a metal cap over the end of the bone. So you just prepare the end of the bone, and then you have a metal socket. So the pluses of this is the resurfaced hip is built on your own neck. So it has the same angle that your neck has, both in every direction. So it restores normal offset, it restores normal length. So it more precisely restores your biomechanics. if we put a hip stem down you, the stem would go down here and it would have whatever angle the manufacturer made it. Now usually they give you two options, and with preparation and templating you can usually get very close to what's normal, but it's not exactly it's not built on your body. The downside of this, however, and this has a lot of downsides, is the only way you can do a hip resurfacing is with a metal-on-metal device, because there's no other socket that you can put in and make it thin enough to allow a normal-sized ball head that wouldn't break. If you tried to make that out of ceramic or plastic, it would break. So the only one that's FDA approved is metal-on-metal, and there's a lot of problems with metal-on-metal, and I'm sure you guys, some of you at least have seen some of the articles in the New York Times about some of the adverse problems with metal-on-metal. So there's a risk of hypersensitivity reactions with metal-on-metal. The other risk with hip resurfacing is you can see this bone down here is much more solid than the bone at the neck. So there's a risk of femoral neck fracture, particularly in people who don't have strong bone. So this is probably not a good idea for patients who are over 60. It's probably not a good idea for female patients because of a higher risk of femoral neck fracture. But it may be associated with more normal hip biomechanics. Total hip replacement is one of the most successful surgical procedures we have. It has excellent long-term survivorship. There's great patient satisfaction. The complication rate's fairly low, and it's very cost-effective when government looks at it. So the question is there room for improvement? And anytime you try and improve something, there's a risk that you can make it worse. So you have to be very, very careful. But there are goals. So people would like to see even fewer complications. They'd like to see hips last even longer, particularly as they're being done in younger and younger patients. You want to have a hip that functions even more normally. So most people have a hip replacement. People don't tell them to run and play basketball and do high activities. But there's some people who wish that they could do those things. So ideally, you'd like to see something that worked even better for more people. You'd want to see there be less pain during the process and a faster recovery, better cosmesis, and lower cost is what government would like. So that, so how can we get better? Well, we can make the implants better. We can, from a surgical standpoint, we can have better anesthetic technique. We can do a better job of preventing infection and take precautions. There are some companies now that are designing what they call smart prosthesis that elute antibiotics over time. We can do a better job of putting the parts in with surgical navigation or intraoperative fluoroscopy or different technologies that may allow physicians to put them in better. And we can change the surgical approaches so the approaches are less invasive. And then post-operatively, we can do a better job of managing post-operative issues, decreasing nausea, vomiting, and then complications post-operatively, such as blood loss. So there's a few different, I'm going to go into some of the different approaches that are used. So there's something called the mini posterior approach, which is it's a surgical approach that's familiar to a lot of hip surgeons. It's similar to the traditional posterior approach. And the nice thing about it is a surgeon who is, let's say, not the most experienced, who used to use an excision this size, can gradually bring it down. They don't have to go from this to this. So that it can be more safe if it's done in that fashion. If somebody, as they get more precise, as their instrumentation gets better, as their experience gets better, they can gradually transition because it's an extensile approach. So there's no reason that you have to be locked into the windows. So really, the complications should be preventable with this if the surgeon has good judgment, if they don't try and overstep their bounds. And the experience of using smaller incisions probably makes the surgeon better at dealing with more complicated patients where the exposure is more difficult, such as people who are maybe morbidly obese or some very, very scarred-in situations, previous radiation, particularly when they used to radiate people at much higher doses, a few decades ago. So that's the advantages of that approach. There are some concerns. So with consumer pressure, some physicians may feel pressure to make even incisions that is too small for their comfort level. And there have been studies that have demonstrated much higher complication rates when people have tried incisions that are too small, at least for them. And to me, they don't say they were small incisions. They don't say they were too small for them, but the fact that they had all those complications to me defines that they were too small for the people that were doing them. And so there is concern for injury to nerves or blood vessels, higher risk of wound problems, and not putting the parts in the proper position. This is an example of doing this type of a surgery through a small posterior approach. And I don't, if people don't want to see this, we cannot see it. I'll leave it up to you guys. But basically, I wanted to show you guys what's taken down. So we talk about muscle sparing. So with this approach, you essentially, the only muscles that are released are these small little, and this is a, that's just a small needle. These are large magnified pictures, but essentially, that's the only muscles that are taken down with this approach. They're called the short external rotator muscles, and those are repaired at the end. But that is an approach that works very well, gives you very, very good exposure, and that is the approach I use most frequently. There's other approaches I use, and I think that there are some advantages to some other approaches, and we'll go through some of the other ones as well. But this is one of the approaches, and this is extensile, so you can do anybody through this approach or a variant of it. You know, if somebody is 500 pounds, you might need it slightly bigger than what we're looking at here. But essentially, it's an extensile approach, and you can essentially get the exposure. That's what it looks like after we're done. The two-incision approach, this is an approach that really has fallen out of favor. So in the orthopedic circles, there's been a lot of negative studies about this approach. It was developed, it got a lot of press in the early part of like around 2000. Initially it was being done as like an outpatient hip replacement. They started in Chicago as well as a few other places. And it definitely was associated with a more rapid recovery initially, but there was a lot of factors. So there was a new anesthetic protocol. There was highly motivated patients, you know, who really wanted to get better sooner, and it was good rehabilitation, and patients were told ahead of time to have these type of expectations. But the results were very, very good initially, but there was a high complication rate at some centers, and that's one of the reasons it's fallen out of favor. It uses internervous intervals. So when you do trauma surgery or any type of, most orthopedic surgery, what you try and do is you try to go in the interval between two muscles that are supplied by a different nerve. So the nerve function to both muscles is still completely normal. That's a surgical principle. Traditional hip replacements, we couldn't do it through a true internervous interval, so you would take down a little muscle and repair it because we didn't have enough exposure. So this was a novel concept that was developed around 2000 where you would use two separate intervals. So you would use one interval to put the socket in, and you would use another interval to put the stem in. And by using different intervals, because your socket goes up in this direction and your stem goes down in that direction, you could just part the muscles like curtains and not detach them by using two different angles of putting the devices in. So that was how this was. One of the advantages of this is you don't have to twist and rotate the leg like you normally do to put a hip replacement in, so the vessels aren't kinked. So this is the example of what the vessel looks like when it's not kinked, and then this is a kinked vessel, which obviously increases the risk of getting a leg clot, which is, is something that's commonly seen with people who have hip replacement. So the potential advantages are it spares the abductor muscles, which is the most important, as well as the short external rotator muscles, which are the ones that are taken down in the posterior report. It may be associated with improved hip stability, maybe better long-term function and strength. Clearly, at least in some of the studies, and some of them may be patient-generated based on patients with higher expectations, but there seemed to be decreased pain with these patients, more rapid functional recovery. It avoids traumatic dislocation of the hip during the exposure, and there's less blood vessel torsion. And you may put the parts in better because you're using fluoroscopy while you're doing it, and perhaps decrease the risk of leg clots. There are some problems. When you're doing this, you can't see the femur as you're preparing it, so you have to do it by feel. So your fingers have to be long enough to palpate. So if the patient's size is such that your finger isn't long enough, you're probably better off not using this approach. There's a learning curve, and you have to worry, it may not be appropriate for all surgeons. The long-term results, at least at that point, had not been established. There's some intermediate-term results now at 9 or 10 years. It requires an increased surgical time because you have to check things with fluoroscopy, and you should have some type of either fluoroscopy or surgical navigation to optimize position because you can't see things as well. I'll show you a little bit of this, but this you can make through a very, very small incision in the front. You can put the socket in. The incision's almost too small for you to imagine a socket could actually even fit through that incision. You know, so essentially the incision stretches out as you're working, similar to like somebody delivering a baby and then contracts back down. So when you see these people, you'd be surprised. They go to rehab. A lot of times the rehab says, no, you didn't have a hip replacement. You had something else. There's no way to get a hip in through that incision. A direct anterior approach is another approach which we use sometimes. It uses the same interval as that 2-incision approach, but it's a larger incision in the front. And by hyperextending the leg, by bringing the foot way, way back behind you and rotating it out about 125 degrees and releasing a lot of the tissue around the top of the femur, you can elevate the femur and put the femur in more into direct visualization through that approach. And that has become more popular as the 2-incision's popularity has waned. I've used this approach. People say that it has similar early rehab as a 2-incision. My experience is that the 2-incision is more it's better early rehab than this in my experience. But I have a lot more experience with the 2-incision than I do with this approach. But I do think that there is some benefits of this as well, because it does give you that same ability to look at the devices as they're going in under fluoroscopy, and it also goes through that same interval, preserving the muscle structures well. But I don't think it has the same early rehab, because you're really twisting the leg a lot with this type of an approach. Some of the non-surgical factors that can also affect recovery include preoperative rehabilitation and patient expectations, anesthetic factors, how good the analgesia or the pain management is, postoperative care, both from a medical standpoint and a rehab standpoint, and the care after discharge. So in summary, there are clear advantages of less invasive hip approaches, provided that increased complications is avoided. But what's really truly less invasive needs to be documented. It's not just a smaller incision, it's less muscle trauma. So the smaller posterior approaches, the direct anterior and 2-incision are very, very distinct, and they all have their own advantages and disadvantages. This remains a major surgical procedure with significant risks, but there's decreasing pain and early function after hip replacement is multifactorial. So it's related to the pre-op rehabilitations, the patient expectations, the anesthetic technique, pain management, medical management, postoperative rehabilitation, as well as how well the surgery is done. We'll talk about knee pain now. So moving on with knee pain, we talk about the location. So inner part of the knee, outer part of the knee, front of the knee, back of the knee, presence of mechanical symptoms, locking, catching, clicking, popping. Is the muscle working? So that's called the extensor mechanism. So that's your motor for your knee. If your motor doesn't work, your knee isn't going to function very well. Ligamentous stability. If there's tenderness along the joint line, that's suggestive of torn cartilage. McMurray's is a test for torn cartilage where you rotate the foot with the knee bent and you have pain at that site. Sometimes you'll get a clunk. And then you can have pain from your hip that you feel in your knee. So just because somebody has knee pain, you can't exclude the fact that their problem may be in their hip joints. You have to be very, very careful to evaluate the hip as well as the back. Diagnostic studies include x-rays. X-rays should be standing. If you're walking and you can stand, a standing x-ray is much more valuable than an x-ray with you lying down. If you're lying down, you're not compressing your joints, so you really don't know what the true joint space is. So you really need to be standing when you get knee x-rays. A lot of primary care doctors get their training as far as muscle injuries in ERs. And in ER, it's appropriate to not get a standing x-ray, because if you don't know if the bone is broken, you don't want the person standing on potentially a broken leg. But if the person walks in, the x-ray should be standing. You want x-rays from the side. A patellar merchant is a kneecap view that tells you whether or not the kneecap is tilted. And then if you get an x-ray with your knee bent, particularly in somebody who's had previous arthroscopic surgery with a torn cartilage in the back, they may have lost some of the cartilage from that torn tissue moving around in the back, but not at the bottom. So they may have loss of the joint space when they bend their knees, but have what looks like a normal joint space when they stand. So they may have a lot of pain, and people may have a difficult time figuring it out because they don't get that view. MRI is a study of choice if you have a ligament injury or a meniscal injury. Bone scan can be helpful to rule out a pain syndrome or to confirm the absence of a problem or rule out a tumor. We'll talk about kneecap pain, what they call patellofemoral pain or chondromalacia patella. That's pain over the front of the knee. It's worse going up and down stairs. It's worse with prolonged sitting. It hurts when you squat, lunge. Anytime you're loading your knee with your knee bent, you're loading the kneecap. A lot of people feel crunching under the knee or crepitus, and there's often a gradual symptom onset, or if there's trauma, direct blow to the front of the knee, your knee hits the dashboard, you fall directly onto your knee, then it can be sudden onset. It occurs in all age groups. The conservative treatment is appropriate for most people. Physical therapy, especially strengthening the VMO. That's the key. Avoid overload when symptoms are present. Rarely a surgical lateral release can be appropriate if the kneecap is tilted but not slid over. And then if it's slid over and tilted, then rarely a realignment may be recommended. But that would be as somebody who's had 6 months of therapy without improvement. This is an example of a kneecap that's tilted and slid over. That's where it is. That's where it should be. That's the kneecap there, and this is where we'd want the kneecap to be. The meniscus is the cartilage shock absorber. The pain is usually on the inner part of the knee if it's the medial meniscus, or the outer part of the knee if it's the lateral meniscus. It's worse with movement, particularly twisting or pivoting type of movers. It's better with rest. Younger patients in their 20s and 30s usually will have some injury that they recall. People who are older, they may have a more degenerative meniscus. They may just be gardening and twist and may not even know that it happened, and then wake up the next morning with their knee a little swollen from symptoms, because the meniscus tears more easily when it becomes more degenerated. The knee can lock or catch. These are called mechanical symptoms. Swelling is common, particularly initially. This is a picture of a knee. This is the meniscus here. They look like half moons. These are the ligaments, the ACL and PCL, and these are the side ligaments, the collateral ligaments. This is the meniscus looking at it arthroscopically. This is the femur cartilage. This is the tibia cartilage. That's a torn meniscus that's flipped. You can see how that can cause mechanical symptoms and can also cause damage to the surface of the cartilage. So the pain can improve with a temporary change in activity, anti-inflammatory medications. Older and less active patients have a better chance of not needing surgery because they're less likely to make a small tear into a larger tear, and they're less likely to be stressing it as much. Younger, more active patients typically are going to stress it to the point that they have pain, or if they have a small enough tear that it gets better, they're usually going to make it into a larger tear later, because once it tears, it's more susceptible to becoming a larger tear. This is an example of a torn cartilage. This is after it's been removed. This is another torn cartilage in a different, what they call radial tear. This is after that's been removed. And this is a tear that's been repaired. So the tear is over here. These are the sutures that hold it in place. The type of tears you can repair are the ones that are out here, where the only part of the meniscus that has good blood supply is the outer third. The inner 2/3 get their nutrition from the joint fluid. It's enough nutrition for it to survive, but not enough nutrition for it to heal. So people have tried repairing the inner ones, they never heal. So you just trim them, you don't try and repair them. Traumatic injuries of the cartilage are often from a sports work injury or a car accident. Untreated injuries can lead to arthritis. Traditional treatment is debridement and drilling. Newer treatments include cartilage cell transplantation. Juvenile chondrocytes are using cartilage cells from neonates to heal defects that people believe have better healing potential. Osteochondral autograft transplant is taking a plug of bone and cartilage from one place in your knee and moving it to another place. Osteochondral allograft means you're taking bone and cartilage from a cadaver and plugging it into an area of your knee. So ligament injuries can be associated with pain and giving way of the knee. There can be a sensation of instability or abnormal motion involving the knee. It's usually associated with an injury such as skiing, a sports injury, football, basketball, or soccer, or a motor vehicle accident, which can be high energy and may involve multiple ligaments injuries, like ACL, PCL, and collateral ligaments. Mild to moderate sprains can be treated with ice elevation, sometimes bracing if there's any instability, rarely surgery. Complete tears, the treatment depends on which ligament is injured. If it's the side ligaments, those ligaments can often be treated in a brace. The cruciate ligaments usually, if the person is going to do high-level activities, usually will need reconstruction. So the surgical options for knee conditions include arthroscopy, biologic resurfacing. Osteotomy is where you cut the bone if somebody's severely bow-legged or knock-kneed to straighten the bone before they get arthritis. Unicompartmental knee replacement is replacement of one compartment of the knee. We'll go into that in a little more detail. Patellofemoral replacement is replacement of the kneecap area. Bicompartmental is rarely done. There's very little data, but there may be some indication. That's two different compartments: total knee replacements where you replace the whole knee, and revisions where you redo a previous knee. So arthroscopy is effective for meniscal tears, loose bodies. It can facilitate ligamentous reconstruction. It's not effective for arthritis. You can't put the cartilage back. If you have somebody who's got a tear, mechanical symptoms, and mild arthritis, and they're young, you may do arthroscopy even though you know you can't fix their arthritis to buy them time. But it's not solving the arthritis. Biologic resurfacing. So if you've got a defect, you can put holes in the bone as we saw in the hip. That can help scar cartilage form. Carticel is taking cartilage cells from somewhere else in your knee, sending them up to Cambridge. They grow them, multiply them, and then they give them back to you, and you can put them under a flap like this. So this is a flap of periosteum of your bone covering that's sewn over this to contain those cells, and that can heal and form what they call hyaline-like cartilage, cartilage that looks similar to your cartilage under the microscope. Whether or not it holds up like your cartilage and whether or not it prevents arthritis down the line, there's not enough time for us to know that yet. So these things are doing pretty well at 7 to 10 years, but most people who develop arthritis from the small cartilage lesions, it takes 20 years. So we don't know whether or not these are going to do well long term. The other ones you can take, we talked about bone cartilage plugs either from yourself or a cadaver or the juvenile chondrocytes. Osteotomy is where you cut the bone. This is sometimes done with some of these cartilage procedures. So this person had a large area of bone and cartilage missing from an injury, but they also had a bowed knee. You couldn't do the cartilage transplantation and leave that knee bowed because you would have been putting that healing tissue under extremely high forces. It wouldn't have worked. So you can correct the angle of the bone and do that cartilage procedure. Unicompartmental knee replacement is when you have arthritis in only one knee compartment. It's in somebody who has an age and activity level that's appropriate for any type of knee replacement. The knee needs to be nearly straight, so they can't have a severe bent deformity of the knee because you won't be able to correct that with just doing one compartment. And they have to have at least 90 degrees of bend because you're not going to be able to tremendously improve their range of motion with this type of a procedure with just the one compartment. They also can't have severe bowing or severe knock-knee deformity because if the ligaments are stretched out, you won't be able to balance the ligaments just dealing with the one compartment. And they got to have arthritis in just the one compartment and no inflammatory arthritis. If they had rheumatoid arthritis and you know they have a synovial process that involves the entire knee, even if the other part of the knee isn't broken down yet, you know it will be. So it makes no sense to replace just one compartment. It's also recommended that they not be overly overweight because there's a lot less surface area for contact, so the device can plunge into the bone if it's loaded too much because it's got less surface area. So this is an example of unicompartmental knee replacement. It is less invasive. There's less blood loss. You can do it through a much smaller incision because the parts are smaller. And essentially, this person has arthritis on the inner part of the knee, and you can put a replacement in the inner part. The outer cartilage is still good. The ACL and PCL are still good. The ligaments, the side ligaments are still good. So this can work very, very well. And actually, the patient satisfaction with this in appropriately selected patients is better than a knee replacement. It feels more like a normal knee because it's got more normal kinematics because all your ligaments are still there, all 4 of your ligaments, and they guide your knee. And it moves much more normally if you look at it under fluoroscopy. So it rolls back much more normally. And it feels more normal. But it wears out sooner because it has a smaller surface area and because you can get arthritis in the other parts of the knee. So it's got another way to fail. So if you select the patients well, the survivorship of this is 85% at 15 years. A knee replacement's 90% at 20 years. So this doesn't work as well, but it still works pretty well, and it's much easier to convert this to a full knee. But if you tried to do this on everybody, your results would be a lot worse than a full knee. If you tried to do it on people who had arthritis that was beyond where this could solve it. This is the same thing being done on the outer part of the knee. Again, the outer part's completely worn down. The inner part is fine. Under the kneecap is fine. And there's a replacement on the outer part of the knee. And then this is this is a bicompartmental. So this is something that there's not a whole lot of data to say, you know, how well this is. Anytime I do this, I have a very, very serious discussion with the patient about is this what they want? Because there's not a whole lot of data to say how effective this procedure is. In a lot of ways, it makes sense for somebody who has 2 compartments because it gets all the benefits of the unicompartmental as far as preserving your ACL, PCL, the more normal kinematics. And if you have problems with the kneecap, it still allows you to do that. But again, there's not that long-term data, so it's something that you have to be cautious with. So this is an example of that. This is the kneecap part of the replacement, and then this is the medial part, and then there's a plastic under the kneecap, but this is that person's own cartilage out here. This is their ACL. So this can work very, very well for the right patient, and this is what it looks like. So it's got two different replacements, and they got good cartilage out here. Again, there's not good data to determine. So we have the 15%, 85% at 15 years for the uni, 90% at 20 years for total. Nobody has data on this yet. They've been doing this in Europe for a little while, but they still haven't really published data. Total knee replacement is highly effective for treatment of arthritis. There was an independent consensus panel from the National Institutes of Health in 2002. It's been found among the most cost-effective interventions in medicine. So when you start talking about quality of life years improved at the cost, there's almost nothing in medicine that does better than knee replacement surgery. When we start talking about surgical approaches, it can be medial parapatellar is on the inner part, and I'll show you this with a picture. So that's medial parapatellar. Mid-vastus is you separate, this is between this is called the vastus medialis and the VMO, and this is subvastus, you go completely underneath the VMO, so you preserve this muscle attachment to that tendon with that subvastus approach. And some people have recommended this quad sparing approach, which is this just along here that doesn't go up into the tendon. That gives you a pretty small window. I'm not a big fan of that because especially if with big parts, if somebody has a large knee, the parts may not fit through that, and there's a very limited time to get that fixation, so I think you potentially could compromise things. But as far as fixation, it can be cemented. That's the gold standard. This is an example of a device that's cemented. Cementless means that the part is put in and it heals directly to bone. That's more commonly done in the hip than the knee, but there are some new devices that seem to have pretty good results now that are cementless, particularly if you've got good bone in a young person. And hybrid means one part's cemented, one's cementless. Bowed deformity, so somebody can have severe bowing like this, and they got large bone spurs. If you release these bone spurs, that will loosen the ligament on the inside so you can balance this and not need a constrained knee replacement. So that's an example of just using a regular knee replacement. But there are times where it's so bowed that you may not be able to do that. And then if it's severely knock-kneed, and this is more for physicians, but you're releasing different muscles to make it straight. Pediatric inflammatory conditions, you lose the space everywhere. Juvenile rheumatoid arthritis, hemophilia, these things are associated with higher complication rates, but very, very high patient satisfaction because these patients have severe pain for a long time and really do very, very well after surgery. When you've had arthritis after previous trauma, you've had previous surgery, the risk of infection is higher because there may be some residual infection from the other surgery. There are people who would recommend putting a needle in to rule out infection prior to doing this. But even if you rule out infection here, there could be infection along the device. You also want to have full-length films to make sure there's not any deformity up here or down there that you may not realize in the setting of prior trauma. And then if you've had a previous correction of the angle of the bone, there's some issues there. So this is a guide. This guide allows us to cut it the way we want to cut it. So we can have this guide, we can line it up, and then we basically want to make that cut perpendicular to the long part of the bone so that the tray is being loaded evenly on both sides, so there's not a tendency for it to want to tilt one way or the other, and so that the knee is straight when we're done, so the plastic's being loaded evenly on both sides. On the femoral side, we can make a drill hole into the center of the bone. We can place a suction device down there to get all the bone marrow elements out to minimize the risk of getting fat embolization. And then we can place this guide, and this guide has different angles so we can predict where we want to make the cut. And there's another guide, and we basically cut through these guides that allow us to make the cuts precisely. And then we can measure the size of that person's femur. So what we want to do ideally is we want to remove the exact same amount of bone and cartilage that was lost as we're replacing with metal, so that when we're done, that leg, all those ligaments are under the normal tension, the same tension that they were at when you finished growing. So we want those to be at your normal pre-disease tension so that they're stable throughout the range of motion. The kneecap, we leave your own kneecap in place. Your kneecap is still attached to your thigh muscles. It's still attached to your patellar tendon. But what we end up doing is we end up cutting the undersurface that articulates with the metal device and putting a plastic button that's the same thickness as the bone that we're removing. So that your kneecap is still there. It's still your kneecap that you feel, but the undersurface of it that moves against the device is now plastic, so you don't get pain from that. So there are several options for inflammatory, degenerative, and post-traumatic conditions involving the hip and knee. Many conditions will respond to non-surgical conservative treatments. When symptoms are not adequately managed non-surgically, there are a number of options involving joint preservation as well as partial or complete knee replacement. Total joint replacement remains the most reliable procedure for advanced disease. Thank you.